So I'm thinking to myself, yay, the blood pressure's better, but what's causing it to drop in the first place? Is it just the expected pathophysiology of liver failure that leads to vasodilation? Is her ascites just so bad that she's compressing her major vessels and not getting good venous return to the heart? Or does she have an infectious source causing systemic response that we like to call septic shock? Or all of the above? And turns out it was all of the above. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. This will be a 4-part series on liver failure. First, we're going to talk about the basics of why liver failure causes so many problems, from coagulopathy to ascites to GI bleeding to renal failure. In the next 3 weeks, I'll be doing an episode on managing esophageal varices, one on hepatorenal syndrome, and finishing it off with managing patients going through alcohol withdrawal. So if you're like me and you love nerdy patho breakdown, you'll love this series. I think that no matter what department you work in, even pediatrics, we've all cared for patients in liver failure. It can be a very challenging patient population, but when we can understand the why behind what is happening with our patient, we can anticipate changes and be prepared for the worst. So let's dive in. I had a student shadowing me this shift, and he was pretty sharp. We've been talking through various patho prior to this patient call, and he knew all the right answers. But this is the perfect example of when head knowledge meets practical application. We got our first rapid response call of the day, and he was excited to take off down the hall together. We got to this patient. She was a 30-ish-year-old female, and I immediately noticed how jaundiced her skin and sclera were. She was edematous in her extremities and had pretty severe abdominal distension that looked like ascites to me. She was kind of lethargic, yet simultaneously agitated. Like, if you've seen that before, you know what I mean? Kind of rolling around on the bed with eyes closed, but when she was awakened, she wouldn't follow commands, was very irritable, like jerking her arms away when anyone tried to assess her or take blood or take a blood pressure. It's just a miserable situation. The rapid response was called for hypotension. The nurse had already given a liter of fluid, and that had helped the blood pressure initially, but now it was trending down again, which is what prompted the rapid response activation. The current blood pressure was 76/38. Upon my initial assessment, she was breathing rapidly, like 30 breaths a minute, and she was altered, unable to follow commands or answer questions, just kind of groaning, but she did respond to noxious stimuli. Her skin was warm to touch and jaundiced, like the kind of jaundice you can see from the doorway. I couldn't palpate her radial pulse, so I believed the hypotensive reading that the nurse reported to me. When I pulled up her gown to assess her abdomen, it was taut and looked like 8 months pregnant. About that time, the ICU resident was arriving, and I asked if we could give some albumin for her blood pressure, since a liter of normal saline was already given. Fortunately, at my hospital, albumin takes a bit to get into your hands. It's not routinely stocked on most medication machines, and it cannot be tubed from the pharmacy because it comes in a glass bottle. So someone either has to walk to pharmacy to pick it up, or a pharmacist has to hand deliver it. Therefore, I asked about starting a norepinephrine infusion in the meantime because I knew albumin was not going to be in my hands anytime soon, and I was looking at an altered, hypotensive patient. Additionally, I had a hunch that she was not only vasodilated from her cirrhosis pathophysiology, but that she was also septic. She felt febrile when I was attempting to palpate her radial pulse and when I was assessing her abdomen. I hadn't had the chance to actually check a temp, but my mom hands are pretty accurate when it comes to detecting a fever. So that being said, if she was septic, norepinephrine is the first-line vasopressor for distributive shock. They agreed, so I mixed up a norepinephrine infusion and started it at a low dose and titrated until I achieved a MAP of 65. The rest of her vitals definitely supported that septic hunch. Heart rate 122, respiratory rate 30, oxygen saturation 95%, and her temp was 38.1 Celsius. So once we got the albumin going and the norepinephrine drip titrated to that sweet spot of a MAP of 65, then we had time to develop a plan of care that reaches beyond the immediate problem of hypotension and hypoperfusion. So she had just come through the ER the night before, and we only had 2 sets of labs to trend, but we could already see her renal function was declining. Her white count was climbing, and obviously all of her liver enzymes were wonky. So I'm thinking to myself, yay, the blood pressure's better, but what's causing it to drop in the first place? Is it just the expected pathophysiology of liver failure that leads to vasodilation? Is her ascites just so bad that she's compressing her major vessels and not getting good venous return to the heart? Or does she have an infectious source causing systemic response that we like to call septic shock? Or all of the above? And turns out it was all of the above. It was going to be a bit until the ICU bed was available, so I pushed for her to go for a diagnostic and therapeutic paracentesis. She fit all the clinical picture for spontaneous bacterial peritonitis, and the only way to truly diagnose that is to send off a specimen of that peritoneal fluid for pathology. And her belly just looked so uncomfortable. I knew that tapping that thing would make her feel better and hopefully help her blood pressure. We'd already given albumin, so in my mind, there was no need to delay the inevitable diagnostic and therapeutic intervention. So we went to IR, tapped her belly, they pulled off 6 liters, and she did in fact have spontaneous bacterial peritonitis, or SBP, for which she was started on antibiotics in the ICU. Unfortunately, this young woman had a very long hospital stay complicated by hepatorenal syndrome and renal failure. Her liver failure continued to progress, and ultimately her family decided to transition her to palliative care, and she was able to pass peacefully, surrounded by her family and the team that had been caring for her for weeks. So I want to take time to break down the pathophysiology of cirrhosis and touch a little on SBP, but first, let's get back to my nursing student. So after we dropped the patient off in IR, we went back to the rapid response office to debrief a bit, and I asked him, so what questions do you have about the case? His first question was, so was she pregnant? And I answered, no, she didn't look that way, but what about her history made her abdomen look like that? And he had no idea. So I asked, what about her history were you able to gather? And he responded, well, I heard the nurse say she had cirrhosis, but I thought I might have heard that wrong since she's only 30 and she looked pregnant. So I responded, no, you heard correctly. She does have cirrhosis. What are some other symptoms associated with cirrhosis? He very quickly responded, ascites and jaundice skin. I was like, yeah, that's correct. That would be the correct answer on the test, but what did you see when we assessed her? He said, well, her skin looked like a bad spray tan. Is that what jaundice looks like? And to be honest, I don't even know what ascites looks like. So I responded, yeah, you got it right. I want you to remember what she looked like forever. That yellowish coloring of her skin that looked like a bad spray tan, that is jaundice. And remember her eyes, like the white part that was also yellowed? And her abdomen was distended and tight looking. That is ascites. So it just goes to show you that you can memorize the signs and symptoms of a disease process or the steps to take better care of a patient or what to do for an emergency. But until you can actually apply it to a clinical scenario, or even better, see it with your own eyes, it's hard to really wrap your head around it at all. That was the case with this nursing student. And that's how I'm wired as well. Once I can actually apply clinical knowledge to a real case, well, then it sticks. After our shift together, he said he would never forget the pathophysiology of liver disease, and I hope that you never will either. So now, let's go into what we talked about regarding the pathophys of liver failure and what the nurse's role is in caring for this patient population. So, there is liver failure that develops slowly over time, like from cirrhosis, and there's also acute liver failure that develops Acutely, like from a medication overdose or a toxin ingestion or an ischemic source from hypotension or a clot impairing perfusion of the liver, or even pregnancy-induced, also known as HELP syndrome. So I'll save all of those acute ones for another podcast, but today, let's talk about cirrhosis. Hey guys, I'll get back to the episode in just a second, but I wanted to pause to let you know that if you love my podcast but wish there were more of these awesome episodes, well, I have great news for you. There is more. My Rapid Response Academy is basically podcast 2.0, plus the huge added bonus of community. I love hosting this podcast, but it's just me, recording into a microphone often by myself. And this extroverted gal who loves to both teach and mentor nurses just wanted more. So in the community I created, I get to teach live every Friday and break down topics that I think every nurse needs to know. From deep dives into the pathophys of every emergency you can think of, to some of the heart of nursing topics as well, like how to advocate with confidence for your patient, how to de-escalate situations, how to deal with bullies on the unit, how to be an amazing preceptor and charge nurse, and some of the mindsets and boundaries that have helped me stay in nursing for the last 20 years, not burn out, and thrive at the bedside. I love the opportunity to answer your questions live, and it's such a joy to see nurses supporting each other in this community. So, if you're an acute care nurse that wants to expedite your growth as a nurse and invest in yourself so that you can provide the best care to your patients, you would love my Rapid Response Academy. So to learn more, I put a link in the show notes for you. Hope to see you there. So cirrhosis is the progressive fibrosis and remodeling of the liver. The liver is scarred, for lack of a better word, and healthy tissue is replaced by this scar tissue, which impairs the liver's natural functioning. Though we often associate cirrhosis with alcohol abuse, hepatitis and fatty liver disease can also lead to cirrhosis. We also often think of the liver as the filter organ, and yes, it does do that, but it's also responsible for the synthesis of proteins, like the important ones, albumin and clotting factors. So when the liver is sucking at producing albumin, this leads to reduced plasma oncotic pressure, which is the fancy way of saying that fluid is going to start shifting out of the vasculature into the third space. As to the clotting factors, when they can't be produced, this impairs the coagulation cascade, and you will see it reflected in your patient's coags, like an elevated INR, or on the CBC with a low platelet level. One concerning side effect of cirrhosis that we saw with this patient was hypotension. The shift in fluids from the vasculature to the belly in the form of ascites causes intravascular hypovolemia and subsequent hypotension. Then, to make matters worse, the dysregulated production of nitric oxide, which is a potent vasodilator, causes systemic vasodilation, only exacerbating this hypotension. The other concern we face with failing livers is coagulopathy. The liver's diminished production of essential clotting factors like fibrinogen, prothrombin, and factors 5 and factor 7. This deficiency contributes to both bleeding tendencies and a prothrombotic state. It's a challenging combo to treat someone who is prone to bleed and simultaneously prone to throw clots. So, speaking of bleeding, often the first thing that brings someone in for medical care from their cirrhosis is actually GI bleeding. Esophageal varices are a common complication of liver failure. They're basically stretched out, dilated blood vessels in the esophageal wall, like big, bulging varicose veins in your upper GI tract. These develop from portal hypertension, secondary to increased resistance to portal venous flow. The fragile nature of these dilated veins poses a significant risk of life-threatening hemorrhage. Because once they rupture, well, remember, they can't clot well either. Yeah, so wait, I'm not done. In addition to hypotension from low oncotic pressure, bleeding and clotting risk, bulging blood vessels that risk rupture in their esophagus, cirrhosis patients also cannot process ammonia. So it builds up in their bloodstream, affecting their brain's ability to function, which can lead to altered personality, coma, and even death. And there is more. The compensatory vasoconstriction of the renal arteries and the compartment syndrome that occurs from that tense ascites can lead to renal failure too, which we call hepatorenal syndrome. We will talk about esophageal varices, elevated pneumonia, and care for patients who are withdrawing from alcohol, and hepatorenal syndrome in the next 3 episodes. But there's one last complication I want to talk about in this episode because it contributed to the hypotension and altered mental status that we saw with our patient today. And that is spontaneous bacterial peritonitis. So SBP is called spontaneous because for a while there, we didn't know how the peritoneal fluid so frequently got infected with these patients who have ascites. But now we're thinking it might be related to two factors. First, there's an overgrowth of gut bacteria due to impaired gut motility seen in patients with ascites. Think like everything's all squished in there and can't move forward. And second, there's increased intestinal permeability. So like the fluid and other things can shift out of the gut. That low albumin affects so many things. So get this. Bacteria within the gut tubes can travel through or transverse the intestinal wall and colonize the mesenteric lymph nodes. This phenomenon is called translocation. Translocation sounds like something from a sci-fi movie, like Spock, hand me the translocator, translocate me to the next dimension. Yeah, so the gut bacteria can translocate from where it belongs, inside the gut, to the peritoneal fluid. Yeesh. So this is not something that can be diagnosed with labs or even imaging. Only a sample of peritoneal fluid can provide the definitive diagnosis of SBP. The treatment is antibiotics and all of the other supportive therapies that we do for someone who has sepsis. But in the face of pre-existing hypotension, impaired renal function, risk for bleeding, poor nutrition, and all the other things that go along with liver failure, SBP is all the more challenging to turn around. The last thing I want to do for this episode is what I did with this nursing student and just go through the different body systems and talk through what assessment findings to look for and anticipate. We'll start with the skin. So jaundice can be seen both in the skin and the eyes. Jaundice is from increased bilirubin levels since the liver can't break down bili in its fibrotic state. You may also note little red or like ecchymotic splotches with spider-like markings surrounding the center circle. They look like little red or purple spiders that can be seen like on the face or the trunk of the extremities. The amount of them present has been correlated with the severity of the cirrhosis disease progression. So these are called spider angiomas, and it often means that more esophageal varices are present and there's a higher risk for complications for patients who have these spider angiomas. Liver failure patients can also present with red palms from splenic and peripheral vasodilation, clubbing of the fingernails, which is not well understood, and asterixis. Asterixis, also known as flapping hand tremor. You've probably seen it before and didn't connect it to the liver disease. It's those like involuntary jerky movements of the hands and fingers and kind of the wrist that can resemble a bird flapping its wings. This is largely associated with elevated ammonia levels affecting the central nervous system. Now, let's move from the skin and the neurological system, your across-the-room assessment, to what you would see when you actually pulled back the covers. So when you assess the patient's chest and abdomen, you may note hepatomegaly or an enlarged liver, ascites or fluid-filled abdominal cavity, and enlarged abdominal veins, meaning the veins appear more prominent than what you would see on most patients' abdomens. You can see in male patients gynecomastia and loss of chest and axillary hair, and this is due to the way the liver affects the adrenal glands. As to taking a history, the patient may report nausea and vomiting from decreased GI motility and possibly coffee ground emesis or even bright red bloody emesis from esophageal varices. They may also have dark stools or melena, again, from bleeding esophageal varices that's been digested into the form of melena. The patient may feel tired or become easily winded from a low hemoglobin and hematocrit. They may have an altered level of consciousness and even an altered personality from their elevated ammonia levels. And finally, with regards to vital signs, hypotension is kind of to be expected. We'll talk more about that and how to treat this in hepatorenal syndrome episode, but in short, even patients with a history of hypertension can become hypotensive when they kind of adjust and compensate for it. So it's not uncommon to let the MAP stay at like 55 or 60 as long as the patient is perfusing their brain, awake, alert, and the renal function is not declining. So in summary, cirrhosis can cause a multitude of complications that affect every body system. They can't produce proteins needed to maintain oncotic pressure or clot effectively. So they can develop ascites and are prone to bleeding. They can develop esophageal varices, which put them at risk for GI bleeds. They can't metabolize ammonia, so they have personality changes and increasing lethargy, even coma from the elevated ammonia levels. And finally, like in this patient's case, that increased permeability in the gut can lead to spontaneous bacterial peritonitis, which causes a septic, systemic response that only further exacerbates the blood pressure. So, what are our takeaways of nurses? I have 3 for you. First, hypotension is just kind of part of it. A little bit of midodrine works wonders to combat the vasodilation inherent with this pathophysiology. Even though we expect a low blood pressure, cause for concern is when the patient's mentation changes. And sometimes it's difficult to say if the mentation changes from hypotension or from worsening ammonia, but it's so important to know your patient's baseline so you know when it's time to speak up and advocate like this nurse did. Second, albumin is gold in liver failure patients. Its efficacy is kind of debated with other patient populations, but for liver failure, there's no arguing with the literature about how albumin trumps crystalloid in these patients with a chronic low oncotic pressure state. They need that volume boost to maintain perfusion to their kidneys and keep the fluid in the vessels as their intravascular volume is so prone to seep out and become worsening ascites. And finally, and this is the most important that I want to leave you with, it's so important for the nurse to be able to articulate all of these changes to the patient and the family. Like, goals of care should be a part of the discussion from the moment the diagnosis of cirrhosis is made and remain an ongoing discussion as the disease progresses. Cirrhosis is not curable. Transplant may be an option, but those are not easy to come by. Every intervention we provide is purely symptom management and complication prevention, as there is no actual treatment to reverse cirrhosis. So, be prepared to speak to what the patient and family can expect as the disease progresses. When they don't understand why dad is acting so different, well, then you need to be able to explain ammonia levels and how important taking the lactulose is. When they're thinking that paracentesis will be the cure they've been waiting for, well, be able to explain why that fluid will just reaccumulate because the failing liver and its inability to produce protein. And when the kidney starts shutting down and the family's so frustrated that the loved one's just not getting better, be able to explain how every body system is affected by the liver. And like I said in the beginning, cirrhosis, it's a tough patient population to care for. But we get the opportunity to care for not only the patient, but the family as they navigate this terminal diagnosis. There's so much more to unpack, and so I look forward to the next few episodes on hepatorenal syndrome, esophageal varices, and ETOH withdrawal management. Till next time, guys.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.